group of 6 people with an interest in community-based research gathered at MGH Chelsea Healthcare Center. And in 2016, the Community Research Program came into its current organization with monthly research and progress meetings called the Research Roundtable. We have a distribution list that reaches over 50 people, a research council with representation from every unit and division in the health center and provides overall stewardship, and an advisory board. Our mission is to support research across the lifespan. We emphasize interdisciplinary community collaborations that target health disparities, advance clinical practice, and improve the well-being of our patients and their communities. And just to briefly build on Dean and Josh's point, with the public health crisis of COVID-19 and when it came to Chelsea, as a research program, we knew we needed to respond in some way in the midst of the public health and clinical response. So our belief has always been that research shines a light on the dark underbellies of inequalities, but it also lifts up the fibers and networks of resilience. And so we continue to meet monthly virtually as our research roundtable, learning from clinical and service observations and developing new questions on how to improve our healthcare delivery with attention to health equity. So with this in mind, I would like to echo the many people who contribute to our program as a labor of love. First, our Chelsea family, the Healthcare Administration, Dr. Dean Exaris and Jeanette McWilliams, the Division of General Internal Medicine, who we are greatly indebted to, Dr. Josh Metley and Libby Williams, the Department of Medicine, the Mongan Institute, led by Steve Bartels. We mentioned the Division of Clinical Research, notably Dr. Jonathan Jackson and his colleagues in the CARE program, as well as Dr. Maurizio Fava, who directs clinical research at the MGH Research Institute. And we'd also like to thank the numerous community members, faculty, and staff who contribute to our Research Council, Advisory Board, and now our newly formed Advisory Board for Clinical Research, which functions as a community advisory board. So I'd like to transition to welcoming our keynote speaker, our very own hospital president, Dr. Peter Slavin. Dr. Slavin is a primary care physician and internist. He's been our president at MGH since 2003. Teaches internal medicine and healthcare management at Harvard Medical School, where he is a professor of healthcare policy. He lectures widely on topics including quality and utilization management, the economics of teaching hospitals, and the state of physician practices. And he will be talking to us today on unmasking of healthcare disparities and structural racism by COVID-19. How community engaged research, am I muted or can you hear me? Can you hear me? Okay. Can bridge gaps and help rebuild trust. And as a program, we also would like to echo our feeling of the immense support we have from your office in consistently supporting community health in every aspect of the mission. So we're thrilled to welcome you here today. Thank you.
Thank you, Julie, for that very kind introduction. It's really a great pleasure for me to be here today. Can everyone hear me okay? Okay, terrific. I want to thank those responsible for organizing this week-long event. I want to thank Josh and the Division of General Internal Medicine for providing leadership to all of our health centers. I want to thank Jeanette and Dean for the inspired leadership they provide at the Chelsea Health Center. And I want to thank other members of the Chelsea Health Center staff who are on this call, who bring all 4 missions of the MGH to life in Chelsea every single day. I also want to thank the Chief of Staff at my office, Shay Asfa, who helped me put this talk together. So if you agree you like it, you can give Shay credit, and if you don't, you can blame me. I, as some of you know, have a real kinship to the Chelsea Health Center. My grandmother, whose maiden name was Dora Levine, was born in Chelsea, and I think around 1910, grew up in Chelsea, and so my family benefited from Chelsea's openness to diverse population, and it was her parents that immigrated from Lithuania to Chelsea, and so we're always have felt a warm place in my heart for Chelsea as a result of my family's experience. In addition to that, I grew up not too far away from Chelsea, in the city of Malden, and spent maybe one of the most exciting summers of my life, maybe with the exception of this past summer. When I was in college, I volunteered to work on my state representative's campaign for the Congress. His name was Ed Markey. He went on to win that congressional race. My responsibility was to coordinate 4 cities and towns in the district, Saugus, Revere, Everett, Winthrop, and Chelsea. And our regional office was located on Broadway in Chelsea. And so I spent one of the most exciting years during my young adulthood helping coordinate his campaign in that community. I've always just been so impressed with the Chelsea Health Center whenever I visit it. It is just the spirit within the health center, the commitment to the community, the quality of the care that's delivered is really makes me feel very good about the hospital overall and what we do in Chelsea every day. So I'm going to talk about, community-based research. Going to talk some about COVID and talk some about MGH and our history in this regard. And so, Shay, if you could please turn to the next slide. Commitment to the community is really in the DNA of MGH. This is a picture of something called the circular letter, which was the letter that 2 physicians, Dr. Jackson, Dr. Warren, circulated to the rich people of the Boston area in the year 1810 to encourage them to give money to a new innovation in healthcare, a general hospital where poor people could be cared for with dignity. In 1810, our healthcare system excluded people who didn't have the means to pay doctors to visit them in their home or who didn't have homes. And so this was I guess the first philanthropic letter that this hospital ever sent out, encouraging people of means to contribute to making our healthcare system more equitable. Certainly the most famous line in the circular letter is the one at the top: when in distress, every man becomes our neighbor. Sure, anybody who's been on the MGH staff for very long has heard that phrase. I think it describes the spirit of MGH as well as any other phrase that I've seen. But other less well-known parts of this letter say, for example, we have then to inquire into the situation of the poor in sickness and to learn what are their wants. And at the bottom, in such a situation, the poor man's chance for relief would perhaps be equal to that of the most affluent when affected with the same disease. So even back to the very beginning concept of this hospital, being there for people with disadvantaged backgrounds, trying to achieve equity in healthcare has been one of the key values that underpins the creation of this hospital. And I'm pleased that that value remains alive and well and motivates much of what we do. On the next slide, just marching through MGH history, this is a picture on the left of Ida Cannon and on the right, Dr. Richard Cabot. Dr. Cabot was a primary care physician here at the hospital in the early 1900s and was very frustrated with the fact that he and other physicians on the staff would treat people when they were admitted, get them all sort of tuned up, and then they would go back to their community setting. And because of this, they didn't use these terms, but because of the social determinants of health, people would decompensate and wind up back in the hospital. And so he teamed up with the woman on the left here, Ida Cannon, to create the first social service department at any hospital in the country, a department which to this day tries to address for patients the social determinants of health, get them plugged into various community agencies that can help them address food needs, housing needs, et cetera, et cetera. So this, in my mind, is another historic manifestation of this commitment of this hospital to doing more than just meeting the medical needs of people in our office or in the hospital, but also reaching into the community and trying to help our patients deal with their health in a community-based setting. And then on the next slide is a bit of a personal story. Again, this is a picture of my great-grandfather on the other side of my family. This is on my mother's side. His name was Louis Toxin. He emigrated from Lithuania around the same time as my father's family, around 1905. He settled in Suffolk Square in Malden. And shortly after he arrived here in the United States, it was involved in an accident that resulted in him developing chronic osteomyelitis of his tibia. His family sort of somehow surveyed what resources were available in healthcare for this problem in an age when antibiotics weren't available. And he wound up getting care at the surgical dispensary within the clinics building at Mass General over a 10-year period of time. His daughter would take him by streetcar from Malden to the clinics building, get his leg dressed with this solution. This is well before there were antibiotics available to treat this infection. And as a result of this treatment, he was able to maintain his leg for 10 years before he required an amputation. My great-grandfather was in the poultry business and could barely support his family. And as I understand it from my grandmother, who escorted him every week, he received all his care at Mass General for free. And so from this story of my great-grandfather is something that really motivates me every day to try to provide high-quality care, regardless of people's ability to pay or regardless of what boat they came over on. And I have his picture hanging in the conference room that I used to use on a daily basis prior to COVID-19. But again, it's a reminder of how this hospital not only has great minds, but a big heart, and really wants to be there for everyone. So turning to the next slide. So this year has obviously been the most remarkable in all of our lives. And on here are a bunch of pictures, including impeachment of the United States president, controversy about the census that is ongoing, the murder of George Floyd, the tragic death of Breonna Taylor, peaceful and unfortunately at times violent protests in reaction to social injustice, the West Coast on fire, RBG dying, and now controversy about her replacement on the Supreme Court, and then a very ugly race for the presidency. And in the middle of all this is a picture of a model of the COVID-19 virus, which has wreaked so much havoc in our country and around the world. We've never, as a society, and I've certainly never seen in my lifetime, us deal simultaneously with so many enormous issues, and the combination of them has really just sort of has just sort of torn our society in so many different ways, and threatens to really rip the fabric of our society apart, although I hope that certainly never happens. Next slide, Shay. So just to say a few more words about COVID-19, and I'm going to just skip to the next slide. This is a timeline of what happened here at the MGH with respect to our efforts to react to COVID-19. It became clear in January that something unusual was happening in Wuhan, China. And so we began to activate our emergency preparedness system back then. That's the same system that responded to the Boston Marathon bombing, the same system that responded to the Providence nightclub fire. And so we, at a low level, began to start doing some planning for this pandemic. We also later in January started to prevent our staff from traveling overseas. And as this pandemic came closer to Boston, our emergency preparedness efforts continued to ramp up. And then when the Biogen conference and the aftermath of that occurred here in Boston, we were fully activated and in gear. And then on the next slide, you can see a list of a subset of the things that we had to do to respond to this virus. And these are a mix of clinical, community health, and research and educational related things. This really drew upon all four parts of our mission. I'll just highlight a couple of them. We, at the peak of COVID-19, the first surge in the spring, we had about 375 COVID-19 positive patients in the hospital. They were taking up about a third of our beds in the hospital. We normally have one medical intensive care unit for patients with problems like viral pneumonia. In April, we had 12 medical intensive care units scattered around the hospital, caring for about 150 intubated patients with viral pneumonia due to COVID. We had to reassign hundreds of doctors and nurses around the hospital. Fortunately, or that may be the wrong term, many of our outpatient practices were closed. A lot of our elective activity was shut down. And so we did have people with time on their hands, and we redeployed them to help care for COVID patients in a variety of ways. Research labs largely shut down as well. And then on the right side, you can see that, I'll get to this later. I mean, we opened or helped open the hotel on the Chelsea Riviera line for people in Chelsea needing to quarantine away from home. And we also played a major role in Boston Hope at the Boston Convention Center. And then on the next slide, I just want to let you know that we're obviously in a much different situation in October 2020 than we were in April. Number of patients in the hospital is running at about 20. But there are some signs that things may be heading in the wrong direction. The positivity rate in this state has crept up from 0.8 to 1.1%, so more people are testing positive. And if you look at hospitalizations across the state, about a month ago, there were about a little over 300 patients hospitalized with COVID-19 statewide. That number is now running 450 to 500. So things here in the state are a little bit worse, and we hope that all the remaining efforts to control this virus through physical distancing, masking, et cetera, will prevent this from raging out of control like it did in the spring. Certainly, there are some things that are pushing in the other direction, though. The fact that we're going to be moving more indoors as the weather gets colder is not a good thing. And then the fact that influenza is going to arrive in the next few months is also not a good thing. Although it is very encouraging that in the Southern Hemisphere, for the most part, influenza has almost been a non-issue this year, because many of the same steps that control the spread of COVID-19 also control the spread of influenza. So we have our fingers crossed that the influenza season will be a mild one here, but it's really important that everyone get vaccinated. Next slide. So one of the observations that happened early on at our hospital and across this community was the fact that COVID-19 was disproportionately affecting vulnerable populations. This slide shows in various shades of color how people living in Back Bay had a rate of COVID infections. This is back in April, about a quarter of some of the other neighborhoods in the city. And if on the next slide, you can see when we were looking at MGH admissions by city and town, Chelsea, city you're in, relatively small population, was the leading source of admissions to Mass General Hospital for COVID-19. So I give people on the medical service a lot of credit for recognizing that whereas under usual circumstances, about 10 or 15% of our inpatients are Spanish-speaking, when it came to COVID-19, Spanish-speaking patients represented half of our patients, which made it clear that it was really Chelsea, Revere, and East Boston that were being hit particularly hard. On the next slide, this is data that we track every day, which looks at the number of admissions to the hospital by day. And you can see this slide goes back to March. You can see sort of the mountain range that we went through that peaked in mid-April. And you can see that we're now sort of in the foothills of that mountain with some sort of random variation since then. And the colors in this bar chart represent the communities that people or live in that are causing those admissions. And the next chart shows that more clearly. It breaks this apart by city and town. And you can see that I'm having a little hard time seeing the most far right part of the slide, but Chelsea is the community in blue, and I guess it's the second from the bottom. And in April, we were admitting 10 to 15 patients a day from Chelsea, And I think we're all pleased to see that we're now seeing a handful a week. I mean, one is more than we would like to see, but the numbers are down dramatically, and thanks in part to all the mitigation efforts that we've put in place and the heroic work that's gone on within the health center. Next slide. I mean, you all know better than me why these communities like Chelsea, Revere, East Boston are disproportionately affected. It happens to be places where a lot of Latinx people live, but it also is a place where a lot of essential workers, people with low wages, people who use public transportation, and people who live in crowded housing conditions live. And all of those conditions make people at much higher risk for developing this disease. There was an interesting study published in the New York Times a few months ago looking at cell phone movement by community, and they found that in rich communities, cell phones were basically stationary at people's homes, whereas in poorer communities, there was much more movement out of the homes, making people in those communities much more vulnerable to being exposed to COVID-19. Next slide. So we have, having made that recognition that Chelsea, Revere, East Boston were disproportionately hit. As you well know, you were centrally involved in this. We worked in partnership with community leaders in those communities, as we do on all community health issues, to ramp up testing. In the case of Chelsea, to help staff with nurses and doctors, this hotel, to distribute care kits to the entire community with masks, hand sanitizer, and health information to try to mitigate the spread of the disease. We participated in food distribution. We tried to respond to growing mental health problem that this pandemic has caused, exacerbation of an already bad set of problems with substance use disorders, and with a specific attention to vulnerable populations, including immigrants and youth. And then I know there were a number of resources that were created across the hospital dealing with a variety of different issues. I won't cover all those, but I just can't thank all of you enough for what you did, and certainly that was vetted by work of people on the main campus as well. I think one of the proudest days I spent during this pandemic, and certainly one of the most memorable, was the day I spent in Chelsea, seeing some of this work up front and personal, seeing how you had turned the health center inside out and created significant testing capacity and created environments safe for patients and the staff was really, really impressive. Visiting the hotel and seeing the doctors and nurses working there and the patients basically in isolation for 2 weeks in their hotel rooms was also incredibly memorable. And then meeting with Tom Ambrosino, the city manager, and hearing how grateful he was for your work was also quite heartwarming. So thank you for everything you have done, continue to do to help with this pandemic. So getting to the topic of research, clearly all of our research, including COVID-related research, is aimed at trying to advance knowledge, try to improve our medical decision-making, and ultimately it's aimed at trying to improve patient and community outcomes. And on the next slide, our investigators have been extremely productive during this period of time. We did see when our labs closed, our research activity dipped to about 50% of its normal level, but it's bounced back completely. And again, for the second year in a row, the MGH research program will have spent $1 billion on research from a variety of different sources. We submitted a huge number of COVID-19 related to proposals to various sponsor types. And on the next chart, we've received over $50 million in awards from the federal government, federal subcontracts, and other funding agencies as well. So it's been remarkable to see the response of our research community as well. And not only has the research community done remarkable research despite this environment, they've also helped out in so many other ways, working in when the research labs were closed, working and our patient care units, distributing food, et cetera. So in my mind, in many ways, community-based research and community health-oriented research is no different than all the other aspects of the research that we do, ranging from fundamental research to translational or clinical trials research. We are committed as an organization to advancing knowledge in medicine and advancing knowledge about what works, doesn't work in a community health setting is an important body of knowledge to try to advance. What's also very attractive about it is that it involves multidisciplinary research teams. It tries to, I think, it also enhances our engagement with the community because they're obviously very interested in the results of this research, are often very involved in conducting the research. And so I think this is community-based research is a way to further engage a healthcare organization like us with the communities we serve. And I think that engagement is so key to our ability to intervene and help those communities with the community health issues that affect them. On the next slide, I just wanted to give you a couple of examples of COVID-related community-based research that is going on as we speak. Maggie Alegria, who I know gave this keynote address a couple of years ago, has this Strong Minds program, which is being applied and studied in people with COVID-19. Erica Warner is doing a study in partnership with breast cancer organizations, looking at the degree to which COVID-19 has affected prevention, treatment of breast cancer, with a particular focus on disadvantaged populations. And very excitingly, Elsie Taveras, who I believe also gave this talk, just recently received a large grant from the NIH to ramp up testing in several of our communities and study the impact that has on access and a variety of other health indicators. So these are just three examples of the kind of community-based COVID research that is going on at Mass General as we speak. Couple of lessons I learned and some ideas for the future. If I had one regret about our response to COVID with respect to our involvement in the community, it was that we waited until there was a problem. I think in retrospect, we should have known there was going to be a problem, and we should have intervened even before it was evident that, even before those spikes that I showed you earlier occurred in Chelsea, Revere, and East Boston. So I think that my hope is in the future we will be more proactive and less reactive. I mean, I'm proud of our reactivity. I think it was more vigorous than any healthcare organization that I'm aware of. But in the spirit of always trying to figure out ways to do better, I wish that we had intervened before there was a problem in Chelsea, because I think we could have prevented some of the problem that unfolded. And this desire of mine is not limited to disaster planning. It applies to all aspects of the organization as it relates to the community and to disadvantaged populations. Next slide. So I guess to summarize, we currently focus on issues of inequity in vulnerable populations, and we respond on an ad hoc basis to them when they are raised. I hope in the future we are more proactively incorporating our knowledge of how issues, be it COVID-19 or other social determinants of health, affect vulnerable populations, anticipate those things, and intervene more proactively. I think sometimes we assume that the existing individuals involved in the initiative have the right skill set, and I think we sometimes need to supplement people involved in various initiatives with best subject matter experts as possible. And again, I hope that rather than working with communities on problems that they're facing today, that we will partner with our community and key stakeholders in all aspects of the study and do those sorts of things more proactively. Next slide. we are going to continue to invest in our entire research program, including our research related to community health. I believe that under Maurizio's leadership, Maurizio Fava, our chief of psychiatry and also head of our clinical research program, a meeting was held a year or two ago where all people involved in community health research across Mass General were invited. And it's my understanding that there were well over 100 people who participated in that meeting. There is much more community health research going on within this institution that may meet the eye. But in an attempt to try to grow that even further, we are making sure that in some of the investments that we as a hospital make in research, that community health research is benefiting from those as well. So we just announced this past week the recipients of the MGH Research Scholars program, or Research Scholars for 2020. And we are being much more deliberate about making sure that this awards like this go to people in fundamental research, clinical research, and community-based research as well. And I was very pleased that Luana Marquez from the Department of Psychiatry was the recipient of one of those awards. Another award, which is for people more advanced in their careers, are these Mass General Research Institute chairs, which are carry an endowment of $2.5 million and support the incumbents. This year we announced 3 new MGH Research Institute chairs, and I'm extremely pleased that one of them is Maggie Alegria, a pretty renowned investigator focused on disparities and the community. Next slide. So I just wanted to share some thoughts with you and want to leave some time for questions and answers or comments. But this is the mission statement of Mass General Hospital as it was amended by our Board of Trustees probably about a decade or so ago. I just call your attention to the fact that unlike most teaching hospitals that speak about 3 missions, we always speak about 4. And the 4th, or maybe historically the 1st, is mentioned in the last sentence here, that one of our missions is to improve the health and well-being of the diverse communities we serve. And we have tried to bring that part of the mission to life every day. I'm very proud of the community health program that we have. I'm very proud of the community health centers that we operate. But I think given what we've been through in the last 6 months, I think we recognize that we as an institution, we as a society need to do even more to address equity in healthcare. You're going to be seeing an announcement coming out relatively soon about an MGH plan and also an MGB-wide plan on attacking structural racism. I've been working with Joe Betancourt here at the MGH on the MGH plan, and have been working with Joe and other leaders across the system on a system-wide plan. And I hope that you will be as excited as I am about the comprehensiveness and boldness of those initiatives they're about to get underway. So again, I thank you for inviting me to participate in this research week, and look forward to any comments or questions that you might have. Thank you.
Thank you, Dr. Slavin, for that wonderful, wonderful talk. And it was very helpful also to hear the aerial view as we look back onto COVID. So I encourage our colleagues to place some questions in the chat. I see they're beginning to develop. As those grow, I'm going to just kick off with one question, which roots itself around trust. And I was interested in your thoughts as, COVID provides an opportunity to build trust in communities and populations that have been historically either overlooked or frankly abused, not only in clinical care, but also in research. So we were interested in what, from your perspective, the hospital is doing to engage communities and provide an opportunity for conversations around trust.
I think we largely do it through our community health program. You do it so well in Chelsea. I think, the relationship between our community health program, the health center, and the city of Chelsea is amazing. It's been amazing for years. I think this pandemic has made it even tighter than it was previously. Clearly we all lived through some harrowing moments back in April, not knowing when the numbers were going to start to head in the right direction, et cetera, and seeing far too many people affected by this disease. But I think, I hope that in communities like Chelsea, Revere, Charlestown, East Boston, people knew before the pandemic that MGH is there to help, and people know in the wake of the first and what I hope will be the last surge of this pandemic that we're there even more.
Thank you for your response. I'm going to encourage individuals to continue to place questions. I see one here from Elizabeth Fonseca. Would you like to ask that question? I'm happy to share it. You can unmute.
Hi, thank you so much for your presentation, for all your leadership, and thanks to MGH Chelsea for leading the way as well. We learned during the COVID surge that the directory that was developed of staff members with language skills was extremely helpful. And to your point, your idea about incorporating different skill sets in planning, I wonder if we could think about another directory that would help us identify staff with skill sets, for example, the food insecurity issues or community-based organizations or whatever it may be, so that we can more easily identify and proactively invite people with this expertise to planning. Thank you.
Yeah, no, I think those are all good things that we should be focused on. I mean, there were so many heartwarming things that happened during this pandemic. I mean, there was obviously great tragedy, but there was also amazing inspiration, and the Spanish language team of physicians that gathered together to supplement and be there for Spanish-speaking patients in the hospital who didn't have access to their families was one of those things. One of the things that's going to come out of this structural racism plan that we're developing is a much more deliberate attempt to communicate to our workforce in at least not just English, but at least Spanish and hopefully other languages as well. But I think you're right. I mean, we need to know in advance what skills, what needs people on our staff have, so that we're not scrambling to find those things out during a time of crisis.
Peter, Josh here. Thank you so much for that talk, and especially for your leadership. There's no doubt that this community really reflects your vision and values, and I really appreciate it. One of the things that we learn over and over again, and learned certainly during the COVID pandemic from a lot of community-based research, is how much health and illness really is a reflection of things that are not usually what we think about as health care, the stuff that the social determinants of health. And increasingly, as you see the research, some of which you highlighted from like Elsie and Erica and Maggie, and we start to do more research, which is about finding solutions, we find ourselves doing things that don't feel like traditional healthcare anymore. Dean ran a hotel, apparently. So, and I'm wondering how you think about us navigating these waters as we get outside of the hospital in sort of what feels like our usual comfort zone and what we're trained to do as physicians, as nurses, and as pharmacists, and think about where we need to be doing some other work and how do we get there, because it seems vast and a little bit overwhelming at times.
Yeah. I've always believed that we need to migrate from being a healthcare organization to being a health organization. I think we and other providers of healthcare, including academic medical centers, have just focused too much on the healthcare at the exclusion of other issues. I think we've done more on those issues relative to others than just about anyone, but I think there's a lot more room to do more. And I think this, again, I don't want to get ahead of the communication about this structural racism plan, but I think there'll be some things in that move us more in that direction. One of which will be to expand our advocacy efforts. We have our advocacy efforts locally, nationally, have been primarily focused on NIH spend reimbursement, Medicare reimbursement to hospitals, things like that. I believe, and this plan calls for us getting out of our comfort zone on an advocacy front and advocating for issues related to the social determinants of health. If we want to advance health, we have to do that.
For the next two questions, I'll first have Chen-Chi Huang ask her question, and then Dr. Steve Bartels. Chen-Chi, would you like to ask your question, or I'm happy to ask him? I'll go ahead just in case. So Chen-Chi Huang's question is, Asian Americans are usually overlooked when we talk about health disparities. Does MGH have any plans or projects that will include these underserved populations?
Yes, we try to stratify all of our clinical data by race and ethnicity, including our Asian populations. And when we find evidence of disparities, we try to intervene. To be frank, we've seen more evidence of disparities among Black patients, Spanish-speaking patients. So I can't point to a specific example where we've implemented initiative relative to our Asian patients, but that doesn't mean we shouldn't, and I expect we will in the future. So we are committed to equity in healthcare. We want everyone to feel like they're getting the healthcare they deserve, and we certainly want to take whatever steps we can to address the dramatic disparities that exist in our society when it comes to healthcare and health outcomes, be it COVID-19 or so many other issues.
Steve?
Great. Thank you, Peter. That's just a terrific talk, and so inspired by your commitment to the community that you've been so clear about in every talk that you give. I was going to ask a general question about equity-based research at MGH and get your thoughts about this. So we conventionally have been very focused on bench-to-bedside research at MGH, and that's been really its heart and soul. And recently, it's been wonderful that the MGRI, Mass General Research Institute, has changed the figure that you look at now that doesn't just end at bench to bedside, but now goes to population, community and population. And that's very clear now, which is terrific. So I'd love to ask the question, how do we make that real? In other words, if we really are focused on equity as central to our mission, it should also be central to our research mission. And if we are really committed to team science that's translational from bench to bedside to community to population, how might we galvanize a model that leads the nation in translational team science that advances equity and really takes the strengths in bench to bedside and then puts on steroids our work and also translating that to community with a real focus on equity-based translation? Yeah.
Steve, I'm not sure I know the precise answer to your question. I agree with the goal, and I will certainly follow up with people like Maurizio and others within our research leadership to see how structurally we can create the right forum for people interested in this research to gather together and share ideas and create more of a community. I will say that, again, in the MGH plan that we will be unveiling shortly related to structural racism. Part of the plan includes some funding for the hospital to support equity-oriented research. I believe that there's $500,000 that we will spend on an annual basis in that plan to support, to help stimulate research in this area. So that's a little bit of a coming attraction.
Great. Well, we'd be happy to help from Mong and also, of course, in advancing this vision for research at MGH.
Yes.
And if I can just say,
yeah, please do, Maurizio.
Thanks, Maurizio.
I think I would love to see kind of a think tank on implementation science that attracts everybody who's interested in this area and becomes really a kind of a catalyst for promoting implementation science at MGH. So we would be happy to support it, to staff it, but you would have to lead it.
Great. Well, yeah. I would love to help in any way I could. Having chaired the study section at NIH on implementation science and seen a lot of equity-based applications, so we'd love to work on something like this if that'd be helpful.
Right.
Let me mention one other issue that is we're in the process of addressing. It's not going to happen overnight, and I actually feel horribly about where we are on it now, and that is the ability of patients who or people in the state who get their insurance through the connector to access our services. We acquired, I guess, what used to be Neighborhood Health Plan, now Always, largely to make sure that people, lower income people, be they in Medicaid or on a connector plan, could access our services. And then through a series of events that I won't go through all the history, but including the removal of state support for the Always connector product, we find ourselves in a place where Always rates for patients are much, much higher than other products in the marketplace. And unfortunately, the other products in the marketplace don't want to contract with us because they prefer to keep their patients at Boston Medical Center or elsewhere. So we are committed as part of this structural racism plan to do everything we possibly can through our contracting to change that situation and make sure that insurance is not a barrier to receiving care at our hospital or across our health system.
We have some great questions coming in on the chat, and I am going to do, or I'm promising that we're going to cover at least most of them. I'd like Dr. Taveras, if she can unmute and ask her question.
Sure. So Peter, a wonderful talk as always, and really terrific to have you leading us and putting community health as part of our mission. I think many of us have been on some recent conversations about everything happening at warp speed: vaccines, vaccine trials, studies in communities and affecting community members. And I wonder if you can speak, you mentioned this during your talk, the importance of doing respectful community engagement and research. And I wonder if you can speak to that a bit, Peter, and maybe also Maurizio. We're at the kind of forefront of really doing very good community engaged work, but we run the risk of groups, industries, others coming in and wanting to do things at warp speed and almost putting at risk our trusted relationship with community members around that engagement. And I wonder if you can speak to some guidance about how we approach that. How do we approach the importance of the work that needs to get done, vaccines, work that's diverse in recruiting diverse populations, with the importance of doing that respectfully and with trusted community engagement? Because we're definitely butting heads a bit recently in that way.
Elsie, I'm embarrassed to be talking about community health research with you listening. It should be the other way around. I recognize that certain disadvantaged communities are somewhat skeptical about our research interests and wonder whether we're necessarily in it for their own interests or just for our narrow academic interests. I think the answer is we're in it for both, but it takes time to build that trust. And when you have protocol to do a COVID-19 vaccine trial, as is about to happen here at MGH with the Johnson & Johnson vaccine, there's intense pressure to get it done as quickly as possible, enroll 2,000 patients at this site in a double-blind placebo-controlled trial. But we need to figure out, as we're doing that, how to reach out to diverse communities so that the people who receive the vaccination or the placebo are representative of the community at large, and the results of the trial will be as generalizable as possible. There was actually an article in the paper today that indicated that the Brigham has, I think about 30% of the patients that they've enrolled in the Moderna trial are minority populations. I hope that we do as well, if not better, here at MGH. So that's a real live example where there's enormous time pressure, but we need to figure out a way to bring the community along and make sure that people have the trust to be willing to participate in this trial. It's so important.
And Peter, if I can add to the folks that really played a critical role in the success of the Brigham, because overall the Moderna trial did not have adequate representation of minorities, was the work of CRCs from our biobank that were kind of redeployed to the Brigham to help them. Those CRCs are going to be in Chelsea to help us with the J&J trial. So we're really hoping to ensure the maximum engagement of patients and populations in the Chelsea community in the trial, which, by the way, is probably, maybe I'm biased because, Mason Freeman has convinced me that this is probably the most efficacious of all the trials. And so I think it'll be critical for us to ensure access to the Chelsea population.
Yeah, no, we certainly hope it turns out positively. I don't know enough to know whether it's the most efficacious, but it's certainly the most practical because requires only one shot, and the vaccine doesn't need to be stored at minus 80 degrees. It can be stored. It can be stored similar to influenza vaccines. So practical nature of getting it distributed to large populations would be much, much better than some of the alternatives.
I'm going to ask Lisa Walker if she'd like to ask her question. We're coming to the last couple of minutes of the presentation.
Sure. Thanks so much, Julie. Hi, Dr. Slavin. I'm the director of the PA program at the MGH Institute and have been thrilled to be able to join some of these meetings and listen to the initiatives. I was a former American Sign Language interpreter and am very passionate about language access. And just in thinking back to your mentioning about the Spanish-speaking physicians who stepped in to fill in some of the gaps for Spanish-speaking patients who were hospitalized during the outbreak. Are there initiatives or things that we can do proactively to think about incorporating professional medical interpreters into the care of these hospitalized patients, given the limitations of PPE and things like that? I'd love to think more about language access.
Yeah. No, I think, at baseline, our interpreter service does a remarkable job providing translation service in dozens of languages, including American Sign Language. I think what happened during COVID is that they were overwhelmed with Spanish-speaking patients. They couldn't keep up with the demand, and that's where the Spanish language interpreter group became so helpful. But anyway, making sure that people, regardless of what language they speak or sign, have access to healthcare is critically important. I think at baseline, our interpreter service does a great job, but we're always looking to do better. So I know that time is more or less out. I just want to close by saying three things. One, thank you for everything you do in Chelsea to bring all four of the missions of Mass General to life for that beloved community every day. Secondly, thank you for your particular interest in community-based research. I think it's terrific and will be helpful to the academic careers of some of our faculty, but more importantly to the health of the community that we're trying to serve. And last but not least, there are a number of issues that you care about that are on the ballot next month, be it the inclusiveness of our society, access to health insurance, access to education, et cetera, et cetera. So please be sure to vote in the upcoming election.
On behalf of our MGH Chelsea Healthcare Center family, our community research program, we want to thank Dr. Slavin and Shay for providing us a wonderful keynote for our 5th annual research celebration. We look forward to welcoming everyone back, not only next year for the 6th celebration, but for all the events that we support over the course of the year. And we endeavor in these new warp speed investigations, but I think it underscores the value of having longstanding community trust in our work. Thank you. Have a wonderful day.
Thanks, everyone. Bye-bye.
Thank you.
Thanks,
Thank you.
everyone.